thanks organizers for giving me this opportunity. Can you see my screen and am I audible?
Yes, sir. Yes, sir.
Okay, so now moving on to this rare subset of the tumors, which is thymoma and thymic carcinoma. I'm going to touch on the pathology classification and ISCs. So as we know that the thymic tumors occur in the mediastinum, and in addition to the thymic tumors, a wide variety of other tumors also are seen in this region, and classification is decided based on the location. But still the thymomas and thymic carcinomas, they are the predominant tumors in this region, especially in the adults as compared to in the children, where the lymphomas and germ cell tumors are more common. Coming to the classification of these tumors, now the WHO recently has made it very simplistic, and we have two subgroups, mainly the thymic epithelial tumors and thymic neuroendocrine neoplasm. And in thymic epithelial tumors, thymomas and thymic carcinomas are and which includes their various subtypes, which I'm going to illustrate in subsequent slides. So before we go into the thymomas and thymic carcinoma, let's recapitulate our understanding about the normal thymus, which is very much important to understand the biology of this tumors occurring in this region. So normal thymus is a lymphoid-rich organ, and which composed of epithelial cells as well as the dense lymphoid cells, and it has two regions, that is cortex and medulla. So cortex is predominantly more rich in the lymphoid cells as compared to the medulla, which is a relatively pale area, which shows Hazel's corpuscles and more of epithelial cells. And not even the proportion of epithelial and lymphoid cells are different in these regions. Even the ISC profile of these cells are also variable. So which these helps, like in the cortex, we do the cortical lymphocytes, they are TDT positive as compared to the medulla, which is negative for TDT and CD1A. So these helps us to understand the biology of the tumors. And even the epithelial cells are more of epithelioid in the cortical region, whereas they are spindle shaped in the medullary region. So the classification of the thymic epithelial tumors, they are classified based on the various histological features, and we have two subgroups, thymomas and thymic carcinomas, depending upon the which predominant cell type. And that's why there is a lot heterogeneous spectrum of these tumors we see, and they are staged based on the extent of the invasion, lymph node involvement, and spread to the various structures. And there are various staging system also adopted, which as a pathologist we have to comment in the resection specimen to decide the adjuvant therapy. We have to keep in mind that thymomas, although earlier it is presumed that they are benign, but they are potentially malignant, and irrespective of the type of thymomas, we have to consider them malignant. So the evaluation of the classification of the thymomas, we have seen the lot of changes occurred, especially in the 90s. But recently, now at least in the last two decades, WHO has come to a standard as uniform classification of thymoma and thymic carcinomas, and they are categorized into the thymomas type A, B. B is further subdivided into B1, B2, and B3, and thymic carcinomas. So there are earlier the B3 was considered to be thymic carcinoma. So now it is uniformly understood that B category is divided into three subsets, and thymic carcinoma is a separate subset, and which is also accepted in the recent classification. About the staging of the thymoma, the classification system which was widely used is the Mashoka-Kaga staging system, and but recently even there are subtle differences in this systems as compared to the TNM staging. And if you see in the TNM 8 staging, there are some categories which were earlier put into the stage 1, stage 2, and stage 3. They are all now lumped into the stage 1A. So there are subtle differences between the classification in the staging parameters. So we have to specify which staging system we are using, and I prefer we should mention both the staging system in your reports. So next is about how does these the classification of thymomas impact on the staging. So if you see the early stage tumors, that is stage tumors, they are predominantly they are type A thymomas, and whereas in the thymic carcinomas we very rarely see the early stage cancer, and that's also applies to the as we move from the B1 to B3 thymomas. Let's move to the gross appearance or histology of these tumors. Thymomas, usually they are the lobulated, well circumscribed tumors, but as compared to if you see the gross appearance of a thymic carcinoma, it can show the variable appearance as similar to any carcinomas with the areas of necrosis and hemorrhage. Classification, how we categorize them. So it is based on predominantly on the which component is predominant, whether it is epithelial predominant component or a lymphoid predominant component. So if it is a epithelial predominant component, then it will be either type A thymoma or type B3 thymoma, because they show the less number of the lymphoid cells. But if the lesion is rich in the lymphoid cell, then it is likely to be B1 or B2 thymomas. So, so this is the histological spectrum which we see across all these thymomas, and I will illustrate some of these examples. Type A thymoma, that is also previously called as a medullary thymoma. It is composed predominantly of spindle cells, but we have to keep in mind it can show the various histological patterns, so it can become challenging, and you will not always see the spindle cells on the morphology, and sometimes we have to use the ISCs to differentiate it from the SFT or other spindle cell tumors. Thymoma type B1, they are predominantly lymphoid rich, and they resembles the normal thymic tissue, and in these thymomas there can be some pale areas which are medullary islands, and you will see very rarely, or we find it very difficult to identify the epithelial cells on the routine microscopy, and only with the help of ISCs, these epithelial cells which are highlighted by this CK19 will become prominent, and you will otherwise you can end up calling this lesion as a acute lymphoblastic lymphoma. So ISC for CK cytokeratin is very much important to distinguish B1 thymoma from the lymphomas. B2 thymomas, here the proportion of epithelial cells increases as compared to the B1 thymoma, and we are able to identify these cells more clearly. And if you start seeing the clustering of these cells, then the diagnosis of a B1 thymoma is unlikely. So moving on to the if you see the mixture of A and B, that is called as AB thymoma AB, in which the pink looking areas are of type A, whereas the other area is of type B1, and each component should be of at least 10% to give a conclusive diagnosis of thymic thymoma type AB, which may or may not be possible, especially on the biopsy, and the diagnosis can be comfortably given only on the resection specimen. Thymoma type B3, here you will see more atypia, but it is not sufficient to put it into the diagnostic category of thymic carcinoma, and the TDD positive lymphoid cells are less than 10%. So although these are the diagnostic categories, but we can sometimes get more than the thymoma which is more than of one type, and in this situation we have to give the percentage of each component of thymoma. And besides the classification of thymoma, the comment on the capsular invasion is very much important. So for that we have to sample the areas which are from the periphery of the tumors, so that we can make a conclusive diagnosis of thymoma, as well as can comment on the resection status. The problematic areas which in the diagnosis of the thymomas are the areas which can be of borderline cases, and the thymomas which has high mitotic activity or more atypia or necrosis. So in those situations, ISC helps to resolve these problems, and TDT and A1, A3 are the markers which are commonly used which can assist in the diagnosis. And for the diagnosis of thymic carcinomas, these are the few markers which assist in distinguishing the thymomas from the thymic carcinomas. So if we have to use the ISCs, there is a list of the ISCs which we can use. Cytokeratins help to distinguish not only the thymomas from its subtype, but also help to distinguish it from the common lesions, that is a lymphoma, because the diagnosis and the treatment is completely different. For thymic carcinoma, CD5, CD117, they are positive in thymic carcinoma but negative in thymomas. And this is how the meshwork of a thymoma can vary across the various histological subtypes, as it is a loose meshwork in B1 thymoma, whereas in B3 thymomas it is a very nice striking meshwork. So also with the help of basic ISCs we can distinguish these thymomas. Another IC which can be used for distinguishing the thymomas, that is a TDT. So based on the proportion of the TDT positive cells, we can distinguish type A thymomas from others. So if you see in any, even in the biopsy specimen, if TDT positive cells are more than 10%, then it is likely to be either AB or B thymoma rather than type A thymoma. Next, even there are some thymic or compartment specific antibodies, but they are not commonly used, but these options are also available for diagnosis. Another diagnostic challenging category is the thymoma, which shows some atypical features, maybe in the form of necrosis or increased mitotic activity. So there is a new diagnostic term which has been put in the WHO, that is a atypical thymoma for this. So these cases morphologically still they are thymoma, but not sufficient to label them, put into the diagnostic category of thymic carcinoma. And finally, about the thymic carcinomas, we can see a lot variety of thymic tumors in thymic carcinomas in the thymic regions, and the diagnostic criteria for them, there should be a clear-cut atypia, and there should be exclusion of metastasis to the thymus from the other sides. And the ISC for CD1 and CD117 can help to support the diagnosis. So it is very much important to distinguish between the thymoma and the thymic carcinomas. But if we come, which is most relevant from the treatment point of perspective of, it is not the histological subcategory, but it is the whether it is a thymoma, thymic tumor is infiltrating the surrounding structure or the capsule. So if it is going beyond the capsule, irrespective of the histological subtype, the clinician will offer the adjuvant radiation or any therapy, and all thymic carcinoma do require postoperative therapy. So this is the summary of diagnostic algorithm for thymic tumors and thymic epithelial tumors. So we do have to apply the WHO classifications, in which now the recent WHO classification, they have mentioned about the essential and desirable criteria. So the subcategorization of thymomas will be easy in future, and if there is any ambiguity in the diagnosis, the ISC should be used for definitive diagnosis. With this, I end my talk, and if I have 30 seconds, I'd just like to touch up. Can I touch up on the molecular aspect? Just one or two slides.
Yes, sir. Yes, sir.
Sure, sir.
Although till date we make a diagnosis based purely on the histological features or use of some additional ISCs, but now the molecular workup is also coming into play in the thymic tumors, and based on some genomic analysis, it has been now presumed that thymic tumors can be categorized into the four subgroups, and which have a distinct molecular profile, especially the thymoma type A and AB. They show this unique GTF21 mutations. So these markers, and now even the immunohistochemistry is being developed for these for this mutation. So maybe in future we will be able to categorize these thymomas not only on the morphology, but also using these molecular subtypes. So with this, I end my talk. If there are any questions, I'll be happy to take them.